Also, shall we go ahead?
We have to start, yes.
By
Yes.
the way, this is 4th of August, and the date was 3rd of August on the screen. So please rectify that.
Okay. So very, very good morning, respected guests. Happy Sunday and happy Friendship Day to esteemed speakers, mentors, Maha IIP, Central IIP, and AHA office bearers and dear all colleagues. I, Dr. Manjusha Sherkar, Chairperson Maha IIP Women Committee and Central AHA member, take this opportunity to welcome everyone in the 19th episode of PATH, that's Pediatricians Action for Health, Adolescent Healthcare, which is consistently running since 2023 under the mentorship of Dr. Atul Kanikar sir in association with Maha IIP, Nasik IIP, and Nasik AHA. PATH is a flagship online webinar focused on discussing the various adolescent health issues. I am today very much feeling glad to welcome today's chief guests, distinguished Maha IIP President Dr. Ram Gopal Chajera sir, our dynamic Honorary Secretary General Dr. Amol Pawar sir, today's faculty speakers Dr. Sunita Manchanda, Ms. Shrestha Chattopadhyay. I also welcome our mentor and PATH Chief Coordinator Dr. Atul Kanikar, President Nasik KH Dr. Sangeeta Bafna, Secretary Nasik KH Dr. Sulabha Pawar, MMC Observer Dr. Anuruddha Bhandarkar, and all the AHA office bearers, central and state IIP office bearers. I can see Dr. Jayan Shah sir here, Dr. Poonam Bhatia here. Welcome everyone. And on behalf of Maharashtra IIP, I'm really happy to present a very popular program before you called PATH. Now I request Dr. Ram Gopal Chejera. I think sir is there. Dr. Ram Gopal sir, are you there? Okay. I think sir is yet to join. Can I request our Honorary Secretary General, Dr. Amol Pawar sir, to give his opening remark? Over to you, Dr. Amol.
Yes, thank you. Then, in absentia of President Dr. Ram Gopal sir, I welcome both the experts, speakers, Dr. Sunita ma'am and Shrestha ma'am, our mentor, Dr. Atul Kanikar sir, Dr. Poonam Bhatia ma'am, Dr. Jayan Shah sir, moderator, our chairperson, Maharashtra IIP Women Committee, Dr. Manjusha Sherkar ma'am, and all the office bearers of various district branches, Dr. Anna Sahib, and each of the delegate. So this is a very well conceptualized 1.5 year back by Dr. Ramakant Patil sir, then President, Maharashtra IIP, and in association with, in collaboration with Dr. Atul Kanikar sir, who is the busiest man in Central AHA, because he is doing multiple activities. He is in various programs at national, international levels, and also various book he has contributed. And he is the core person of Central AHA. Many faculties seek his advice in in preparing various PPTs and all these things. It is not it is all truth, sir. So and also Nashik AHA team last year, Dr. Sucheta Malodkar madam, Reena Rathi madam, and this year Dr. Sangeeta Loda ma'am and Dr. Sulba. They are all contributing, and under the guidance of Geeta Patil ma'am, chairperson of this year Central AHA, and Dr. R.N. Sharma sir, last year secretary and present office bearers of Central AHA. We are going ahead, and this time Ms. Shrestha Chattopadhyay, she is a clinical psychologist, and Dr. Sunita ma'am, they consented that they will be speakers for this session. So I thank you to both of them, and also Dr. Poonam Bhatia ma'am, she also coordinated for to get these esteemed faculties for Maharashtra IIP and Nasik AHA. So I once again thank all of them, and wish all the delegates happy learning. Over to you, Manjusha ma'am.
Okay, thank you so much. Amol sir, you are being rock support for many MyIP platforms. So thank you so much for your kind words. Can I request Dr. Atul Kanikar sir? Let us know what is PATH actually doing and what is the concept of today's two talks. I sound them little different and very promising topics. Over to you, Dr. Atul.
Madam, nothing is more promising than Dr. Manjusha Sherkar. So it's a privilege to be here always on the first Sunday of every month. And Path is, I don't know, people don't want it to stop. It has been Ramakant Patil sir's idea and super boosted by none other than Amol Pawar sir. And they have actually pushed me into this, but it was my first deep sort of. I was thrilled, and now I really can't live without this particular program. So the day it is stopped, I retire from AHA. You know, so path is now crossing limits from general pediatrics, general adolescent care to sort of specialities and super specialities. And now we have included so many other teams also, gynecologists, clinical psychologists, psychiatrists. So we are having so many plans. Let us see day by day how things progress. But here I request you all to join our Nasik Adlis Con, which is going to be in the last week of September. And if you're not registered, please do it. So, and do join us. It's going to be a great learning experience from people all over the country. And we are expecting some senior adolescent care pediatricians also, in addition to some gynecologists and psychiatrists, all those people. So, please do come to Nasik. We are welcoming you with open arms. So, over to you, Manjusha madam. I
Yes,
think
sir.
your hair are well done, so there is no need to do this all the time. So it's okay. So we can start the
Okay.
show.
Thank
Yeah,
you.
please
Yes,
start
yes.
the show. And
Thank you, Dr. Atul.
today's topics are really very interesting. I wish there is a good learning experience for all of us. So please begin the session. Thank you.
Yes. Okay, thank you. Thank you, Dr. Atul, sir. Now let us open our science today. I invite today's first faculty speaker, Dr. Sunita Manchanda ma'am, to deliver her talk on mental first aid. Uh, Before that, let me give the introduction, formal introduction of Dr. Sunita Manchanda ma'am. Ma'am is consultant pediatrician and adolescent specialist at Gurgaon. Ma'am has honored the post of North Zone Coordinator Central AHA in 2023. She was the President IIP Gurgaon 2020 and 21. Ma'am was State Coordinator of IIP NNF NRP FGM project in 2018. She was Chairperson E-Poster Committee Harcon and Harnicon 25. She was a member of Editorial Board Haryana Pedi News 2013. She was a workshop coordinator for many workshop program coordinators for PG students. She was a co-chairperson of CME Committee Pedicon 2012. She was a faculty and she is a faculty and master trainer of MKU, AYA, SATSAT, POXO, Adolescent Counseling and AKI LSE. Ma'am is academic contributor to Teachers Module AHA, IIP The Child. She has many research and publications on her name, and she is a contributor of the book on counseling skill, TAPH, IPAHA textbook, and counseling skill, etc. Thank you, ma'am, for joining us as a speaker faculty today, and we are really eager to hear to you. Now, let me finish the CV biodata of our second speaker also. Then we shall start with the first talk. Dr. Pallavi. Pallavi, ma'am, can I have? Yes. She is our second speaker, Miss Shrestha Chattopadhyay. Shrestha is a dialectical behavior therapist and she's a registered clinical psychologist accredited by the Rehabilitation Council of India. Is currently pursuing her PhD at University of Kolkata with a passionate commitment to mental health advocacy education. Shrestha has cultivated a multifaceted career spanning psychotherapy, research, teaching, and community outreach. She completed a prestigious 2-year fellowship at Tata Medical Center, Kolkata, specialized in palliative care and psycho-oncology, and has since provided consultation to various organizations. Over the past 3 years, Shrestha has served as an assistant professor, currently holding the position of assistant professor of clinical psychology at Rashtriya Raksha University, Gujarat, India. Her scholarly contributions encompasses a broad range of psychological areas, including liaison psychiatry, psycho-oncology, cognitive behavioral therapy, mindfulness, supportive therapy, Indian psychology, and qualitative research methodologies, along with the proficiency in psychometry. Oh, so exhaustive and very enthusiastic CV for Shrestha Chattopadhyay. We welcome, Maha-happy welcome you, Ma'am Shrestha. Thank you so much. Now, can I request Dr. Sunita Manchanda, ma'am, to take a stage and start the lecture?
Yeah. Good morning, everyone. First, I would like to thank Dr. Manjusha for a nice introduction, and would like to thank Dr. Amol Pawar for giving me opportunity to be part of this program. And also, I would like to start my talk by paying regards to Dr. Atul Kanikar sir, Dr. Poonam Bhatia, and the team Maharashtra AHA IAP, and IAP Nasik and AHA Nasik. So shall I start sharing my screen? So just give me a minute. And so is it visible?
Yes, ma'am. It is visible.
Yes, ma'am.
Kindly make it full screen.
Yeah. Is it coming as a,
Yes, ma'am. Yeah. Yes, ma'am. Yes.
So, right. And before I start, I will request Pallavi, the IT person, please give me a reminder 5 minutes before my talk so that I can finish within time. So the topic for today's talk is mental health first aid. The thing is, why the pediatricians are talking about mental health first aid. We are more interested in NICU, PICU, and intensive care. And now pediatricians are talking about this mental health first aid. See the few scenarios day by day going. A student drop out from college because of exam anxiety. Engineering college student left the college because he was not able to adjust there. Quota students committing suicide. And 30-year corporate employee has to change his job frequently as he has panic attacks whenever he gets information about assessment. Teenage girl commits suicide when had breakdown. The last, which is important for us to know, the 8th standard student commits suicide as the parent refused to give mobile. See the scenario where we are going. And this 8th standard student means 12 or 13 years or maybe younger than that. They have only the parent or grandparents as their caretaker. And nowadays in the nuclear family, they are having the working parents and the maid or the other caretaker. And we are the second person who come in contact before they go in towards the psychiatrist. So having said that, that is the thing for these people, for these kids, we need, it is high time that we should also learn about mental health first aid. As we know, after in this post-COVID era, mental health issues are increasing. We all know we are, coming across daily persons who are suffering from some or other mental health, may not be disorders, but yes, issues. And we know still social stigma is associated with this. And how many psychiatrists, and if we ask how many child psychiatrists in India available, I'm sure we won't be able to, name them also. And another thing which we have noticed is sometimes nowadays the people are not even aware of, yes, that they are having a mental health issues, and sometimes they don't know how to do, what to do, whom to go, and at the same time, whenever they go there, the financial reason. Nowadays, counseling, if they go, I have a discussion with the counselors. They say that more than 50% dropout is there because the therapy, which it is becoming very costly in the private setup, and the government setup, we all know, is too much occupied. And well, adding on to with the statistics, globally, it's a 1 in 7, means global burden of mental health in 10 to 19 years old is 13%. naming some anxiety disorders, depression, which is gradually, in fact, I won't say gradually, it is rapidly rising in these days. And by 2030, depression alone will be likely to be second or third leading contributors to disease burden in low income and middle income countries. Are we ready to handle this much of, the disease burden? I'm sure we are not. That's the reason that we have, not even pediatricians, I think every sector of the society should come forward to, or mentally, or prepare ourselves to handle this burden. And among that, suicide is the fourth leading cause of death. India, we have a limited data. There has been a national family health surveys that was in 15 and 16, and now they are coming up with the NFHS second data. We maybe in the new next 2 or 3 months, we will get an idea. But the thing is that idea is also, or that statistics will not be complete because it is just a survey carried out in few states, not even in the all states. And few of the survey reports says that in India also, the global burden of mental health issues in adolescent comes around 14%. But the thing is, 80 to 90% have not sought support, which is, double the amount. Like, for example, in one of the UNICEF, statistics, they say at least there the people, 80 to 90% people seek help. There, it means in developed countries. But in our country, this came out to be 40%. And meta-analysis shows that post-COVID, if the child is having or the person is having a previous COVID-19 infection, this is 2 times higher odds of having anxiety. And also one of the survey, 2023 survey of 787 North Indian medical students found that 37.2% have suicidal ideation, 10.9% have suicide plans, 3.3% have suicidal attempt. See, are the person, doctors, healthcare professionals are themselves healthy enough to take care of this burden in the society? That is a big, point, and that is why we are here. As far as this training is concerned, a little back, because it is not that like neonatal resuscitation, intensive care, CPR, we also need a training for this. This training, first mental health training program was developed in Australia in 2001 by a research team led by Betty Kitchener and Anthony Jong, which was created to teach members of the general public to provide initial support to the people experiencing mental health problems. In India, 2017, there is an organization, MHFA India. They have become a licensed provider of mental health first aid program. But that formal training will take a time. Before that, I would suggest the AHA has been dealing with all these scenarios, are also taking into consideration of mental health of the children as well. And so it would be a nice idea to join the AHA. And as Dr. Atul Kanikar sir has said it, that there is a workshop, this Adolescon hosted by AHA Nasik. So they can get a not formal, but much, needed training from these organizations. So what exactly is MHFA? It is the first and immediate assistance given any person experiencing or developing a mental health condition or experiences mental health crisis. This is not that we are going to treat it. We are going to give it too much, help to the person who is having mental health disorder or issue. It is the aid or the help given till they are ready to get that appropriate help or their crisis is resolved. Definitely, it is not at all a substitute of the definitive treatment, maybe in form of counseling, support, or treatment. So, as we said, what does it covers? It covers first is symptoms or training to understand the symptoms and risk factors in common mental health disorders like depression and anxiety. These two disorders are definitely going to increase, rapidly. Second is the crisis situation. Now, the crisis situation can be, which is associated with mental health issues, maybe panic attacks, maybe suicidal tendencies, crisis post-trauma, like event of death due to COVID in certain in the past, or maybe a death unexpected by accident in the family. It may be a drug overdose. It may be a behavior which is appearing threatening to themselves as well as to the society, or maybe a burnout or nervous breakdown in a normal, so-called healthy, mentally healthy individual. We all are prone to breakdown. So I'm just having this picture is clearly telling us why people break down. It may be something very easy, very small thing for us, but it might not be the person who is experiencing breakdown. Sometimes, as has already been, exams, not able to pass exams, breakdown, and the scenario is increasing. Now they don't have a breakdown. That is also a cause of stress. So if you want to be stressful, there are so many reasons for stress, being stressful. Then what does it aim? So ultimately aim is helping the person. Like once I remember Dr. Chawla has said that the main thing is कि अगर कोई person डूब रहा है तो उसको पहले lecture झाड़ने की बजाय ऐसे तैरना आना चाहिए, ऐसे तैरना आना चाहिए. I'm sure Hindi is okay ना? Hello? Yeah. So उसको पहले डूबने से बचाओ तो सही, उसको पहले निकालो तो सही. That is, I always remember his wording. So the crux of the, this is help the person so that he is able to help himself. So it means that it helps in preserving a life when the person may be danger to self or others, or it may provide help to prevent the problem, like anxiety issue of today changing into the anxiety disorders of the later, or promote and enhance recovery. So this approach, what does it say is LG approach. The 5 components of MHFA, where to begin? Like it has got 2 components. One is a private practitioner, general pediatrician, and another is, I'm sure, as the AHA members are also there. Probably they know most of the things, but for the general pediatrician, I would say that this is very important if we can have, idea about this approach, ALGEE. Number 1 is assess risk of suicide or harm. Second is listen non-judgment. Third is give reassurance and information. Fourth is encourage person to get appropriate professional help. Fifth is encourage self-help strategies. I'll talk about this in short because we cannot, teach at this point of time in a 20-minute scenario. But yes, having a fairly good idea about the MFHA and the places from where we can get the training. So number 1 is assess risk of suicide and harm. It is a specialized area. So here the suggestion to the general pediatrician is if they are not trained if they do not have any kind of training as we being provided by our AHA, it is better to refer them to the adolescent pediatrician. That is the first thing they can do. Otherwise, in Central IIP, we have got various programs where the material is definitely there. It is Mission School Uday, which from where I have taken this slide. But apart from this, there has been Mission Kishore, MKU. Then third is the AYA, Adolescent Youth. Every one of the members of Central AHA has contributed to them. So idea is the most important in that case is the heads assessment, which is actually the history taking in an adolescent. And secondly, the various office-friendly screening tools. If we are aware of these tools, for example, suicide risk screening tool, ASQ4 for depression and anxiety, we have got PHQ and SACRED. For substance abuse, we have CRAFT, SABIRET, and for internet addiction, Kimberly scale, or many easier scale as well are available. If we can have these scales idea about it, it will be really good for, general pediatrician with a little bit of training to help the person. The most important thing is sometimes we say that it is better not to talk about the suicide to the person who is having a dementia. But their research says that there is evidence that it is better to talk to them. What is their ideation? Have they plan? Discuss about suicide. It definitely is not going to increase the risk of suicide. Second is listening, non-judgmental. This is very, very important. See, how do we listen? Well, in the talk also, somebody might be sleeping. Sorry to say that sometimes we just, webinar, even we are listening, but our mind might not be there at that point of time, occupied certain other things. So listening is like if a person is depressed, at that point of time, if we start giving them suggestion, you do like this, you go to temple, you go to, this is a public which tells them, you wear this moga, you wear this neelam, something that sort of things. Or otherwise, we also at that point of time sometimes start giving suggestion to them. You do yoga, okay, don't talk these things, again and again. You are sounding crazy. You're always like this. See, your problem has a solution. I can help you. I can give you a solution, but you are not willing to do that. All this kind of conversation or, is not going to help that child, the person. What is going to help? We just have to listen him. So I'm just reading these few lines as if they are said by the person who is having a, going through a difficult phase in their life. So what he wants is, according to him, what is the listening? I know you are listening if if you do not take problem from me, but allowing me to handle in my own way, in my own time. Second is, if you are listening, if you are not holding yourself to give, if you are holding yourself not to give me advice, you are still listening even if my talk is making you feel tired or bored at the end of talk. You are listening if you are not providing me any religious solace. You are listening if you are trying to understand me, even if I'm not making any sense. You are trying to, you're listening if you grasp my point of view, even if it is against your conviction. So the point is, you are giving a listening to the person, not, you know, suggesting. It's just that you're telling them, yes, you are available and he's not alone in this world. He is important to you. Or certain times, I love you, I believe you. So these kind of wordings will help these these persons to come out of their depression. Third is give reassurance and information. So this reassurance and information is reassurance in a way like which the supportive things you can say to support someone. I'm here to talk when you need someone to listen. Here I would like to share one example. We had in the hospital three, GDA, general duty attendant. They do some course during their 12th class, and now they are working as a Aya in our place. So one day she had some problem and she was talking to me. I said, Dekho, apni, you can find a person of your age and also, talk. The answer to me was, Madam, अब किसी के पास जाते हैं, हमारे बोलने से पहले वो ही अपनी problem बोल देता है. So somewhere they are not even finding a person to talk. It's easy to say that, yes, I'm here to talk when you need, but are we really there? And if we have to there. So then what I did with her, I said, okay, if you have any problem, I'll give you 5 minutes during, my this patients in the OPD time, you can talk to me. So she's fine otherwise. I mean, I'm just giving you an idea that we have to check that yes, the person is available. Then we haven't had a chance. Sometimes you know that they are recovering from the depression, coming out, then you can give, okay, come in together, have a cup of coffee, and we can go for a walk. And during that, you keep on telling them that you are important to me, you are important to other people. I believe in you. At the same time, start giving them slightly insight of the problem from your perspective. Not that this is the problem and this is the solution. You just give them the choices 10 minutes. So you can give them the choices. So one is that you are giving reassurance. At the same time, information. Now, it is not that every time you can provide the information, especially in scenario of adolescent. बच्चों के parents को तो हम फिर भी बता सकते हैं, but not to them. For them, we have to give all the information in advance, maybe in clinic. I this shared just not to talk about bullying, but it is just that these kind of informative pamphlets we can put in our OPD so that whenever they find, okay, they might be suffering, but at least they can come and talk. And then it is a time that we talk to them in details. For example, the safe approach in a child or in adolescent suffering from bullying at their workplace. Fourth is encourage them to seek professional help. It is very, very important, but at the same time, tough also, I would say. I just recently, I had put a, some cartoon over there where it says, शिक्षक द्वारा दिया गया ज्ञान तो सिर के ऊपर जाता है, माता पिता की बात सिर के close level, दोस्त की गोबर सलाह भी दिमाग में जाता. The point is this, recently I have one student of 2nd class. He came to me for constipation. I, asked the mother to get the nutritional advice and come at this time to me. So I called her for the treatment or education regarding management of constipation along with the medication. And it was a raining season. I was nowhere. There was no time for me to, no, I could not go outside. So he was telling, and mother shared that this child is having stammering. So I said, okay, talk about that. And I started talking about with the mobile thing. And you won't imagine this child who's a student of second class is talking about, I had one YouTube channel. I have to make another YouTube channel. I want my friend so-and-so has got this many likes. I want this likes. I want to learn Japanese. I want to learn Chinese. And I was like listening, giving him a listening, trying to see. It was not like a childish behavior. मैं doctor बनना चाहता हूँ, मैं police बनना चाहता हूँ. No, it was a kind of something in the mind. He was in a hurry to do so many things at a time. That was the facial expression. Then, and the surprising thing was, mother was also listening to it. Normally, mothers, what they do is they stop their child. Oh, बस बात मत कर, बहुत बोलता है. They stop at that point of time when the child tries to talk in front, with us. So she was listening calmly. Then she came out with the thing that this child, they are actually helping him so that he come out whatever is in mind, because he had a game. He was playing game on the mobile, and in that case there was a countdown. Okay, life is going to end, and your countdown starts now. It was, oh my God, that kind of a shocking, or those kind of reactions were there. And he went to friend. Friend said, "Nahi, even if it is close, your countdown is going to start." And then these thought processes reflected in his behavior, where the mother and parents got aware that what is happening to the child, and then they had spoken to, therapist also, and then they came to me also, and we discussed in detail. The scenario is like these small kids who are coming to us, which we used to say, oh, full of life, they are so much of stress, which is not given verbally to them, which is given through the mobile or through internet or through social media, that their self expectations has rise. पहले बोलते थे कि parents की expectations है. Now their self expectations are rising to the extent that this child, if not given attention at this time, is potentially going to have that anxiety, issues later on, and may turn into the anxiety disorders also. So it is very important that these issues, at least, taken care, whatever help as a pediatrician we can do. Otherwise, we have a team of adolescent specialists who are very well trained and can take care of things. And of course, the psychologist, if needed, psychiatrist, counselor, and we should be aware of which psychiatrist, which psych counselor we are sending them, because chances of this follow-up, lost follow-up, are more if we are not in touch with the counselor and the psychologist. So encourage them at every point to seek professional. It is not that you have said it today and they will come tomorrow. No. Aaj batayenge, they may go after 6 months. Please keep on telling them. Fifth is encourage self-help strategies. Here, as far as this LG approach says that, okay, self-help strategies means now the person is with you, rapport building is there, and you are helping, and he believes you, he trusts you. Also at that certain time, you can help them with the self-help strategies. These self-help strategies, do your things, dancing, music, or at least ask them nowadays to have a toolbox. Toolbox, apart from the information, apart from the mobile, etc. It may be in the form of self-talk, talk to a friend, walking in nature, shopping sometimes, depending upon the financial, thing at your home, not always. Watching a movie, reading a book, playing with pet. There are so many things. guide these kids, or in fact, now everyone should know that they should develop a toolbox. It is important because nowadays the kids are going for formal plays. After the school, they are going to skating class, they're going to drawing class, they're going to dance, something or which is all formal. Formal training is again a little bit of pressure to the mind. We want them to have something, keep for themselves informal way. And healthy lifestyles, we all know, I will add on the component of spirituality in it because nowadays it is getting more, and mindfulness, which is coming up with that. So identify stressors. This identifying stressors is when the therapist, they are going towards the definitive management of the person or the patient. They tell them that how can they identify their stressor, which is a big class if I would take that. So at least once they have learned to identify their stressor, we are there to help in reinforcing them that, okay, identify your stressor and act accordingly. Right. So another most important thing with this is self-help strategies. I would say this is not a self-help for themselves. Sometimes the people or the pediatrician who are going into mental health because we are not formally trained into it, at least I personally has felt in the beginning when I started counseling, I used to feel low 15 days, 20 days. I could not understand what is the reason. Whenever I talk to some adolescents having issues, 1 or 2 sessions I take. Later on, when I, had a self-talk with myself, I got to know, okay, something is disturbing me also when I listen to them. So initially, I used to take only 1 or 2 patients per month. And gradually over the time that now I have learned, okay, it still affects, but maybe for a few hours or so, where I know that this may affect me. So I take care of myself also. And at time, if we are not able to handle, sometimes we have to say no also. Like, for example, I know one of my colleague who is a doctor and whose real sister having a mental health issue. Every time she talks to her, it was affecting that person also, the doctor who was helping that. And in between, she just completely shut down from that person. Okay, I can't take it anymore. So sometimes these are our limitations. We have to accept that. Along with encouraging others to develop self-help strategies, we also, help ourselves. That is another part which I had, thought about of adding in it. Having said that, all the things which we would do, here it is like it says, um, this is just a kind of poster which we can put in our clinic that how to support your child's mental health. बशर्ते कि पढ़ने वाले पेरेंट्स इसको पढ़ना पढ़े rather than फोटो क्लिक करके घर ले जाएं कि हम घर जाके पढ़ेंगे. I try not to take picture. I said, okay, please listen here. That is important. But then we have to listen to parents as well. Here, I would like to add few more, how much time I have, Palvi, please? Hello?
Ma'am, just 3 minutes more.
Okay, so not, in time only. As far as I shared the example of one child who was second class and he was able to share about his thoughts with the parents, the teenagers are not going to share thoughts so commonly or so easily with their parents. And parents also come to know about themselves when it becomes too late, or when they know about it, there is a reluctance to take help to come to the pediatrician or adolescent health specialist. So a word about that. We teach these adolescents, this is one of, you can say, self-help or a kind of a help to them. So we tell them 3 things, which is in part of emotional vaccine, we can say, apart from the normal vaccination, which we do that. Awareness of emotions, awareness of thoughts, and thought control. 3 things are important. How do we do that? I just share with one of the example. I had one patient of hypothyroidism getting treatment for long from me, and also was under care of endocrinologist. One day I observed having a conversion disorder in my clinic, in the the NGO where we were there, 2 or 3 pediatricians and 1 counselor was there. Suddenly she developed having a abnormal movement. So at that point of time, counselor somehow luckily was there. When her episode was over, they talked about, she took a 1 hour session with her and she come out with one thing, that this girl has, she was a girl about, I think 14 years, it has been a long time. And in the school, belonging to low socioeconomic status, studying in a government school, in the government school, one of the male teacher had said that if you do whatever, something, or if you don't do something, as a punishment, I would ask to take off your clothes. Actually, he was talking to the boys in the class, but somehow this girl has taken that and, too much into their mind that it has came out with conversion disorder. And I had a word with counselor. I said, no, this can't be that. This something, which is very not a very at that point of time कि ऐसा मुझे नहीं लगा कि बहुत बड़ी बात है, but yes, it has affected her. So the point was thought. That is called as awareness of thought. I am not taking all the things. I just coming to one, the central one, jumping to conclusion. Like sometimes हम अपने आप ही conclusion में आ जाते हैं without knowing the fact and without. Sometimes some few people have a kind of, saying it कि मेरे तो हमेशा ही, गलत होता है काम. Yeah, sometimes even if they are academically strong, but they will say, पता नहीं मेरा तो हर बारी खराब हो जाता है. Other person are taking him as academically strong, but they themselves think about themselves, नहीं हमारा तो ये गलत हो जाता है, because they do not realize कि जो अच्छा किया है, they forget about that. So this girl also had really this thing in the mind, no, he will do that. He was looking at me, he will do that with me, he'll make me, to stop, to take off clothes. So these things were there. So then what we did is, I myself talked to her, the counselor talked to her, the counselor spoke to the school teacher, even parents were asked to talk to the teachers. And ultimately we tried to kind of modify their thought process, and at the same time reassurance from teacher and the supporting. So we had, kind of, that is the thing that we have to make aware these adolescents of their emotions. कई बार emotion के लिए तो आजकल emojis हैं ही. We can take help of these emojis also to what they are feeling and what is the thought behind it. And how did we manage this? It was by the self-talk, any of the technique we can take it. To the adolescent, we talk about this high thought control, which is the amygdala, that they are impulsive. Their thought process is being taken care by the prefrontal cortex when they will become, when they will they'll reach up to the age of 20, 25. Till then, this 6-second models I have taken just because that in the anxiety people, because anxiety is really coming, rapidly rising. In these adolescents, we can teach them 6-second models is like 3 components. Know yourself means, are they aware of themselves in a right way? They're aware of the things. Choose yourselves. That is called as a self-management. That we apply consequential thinking. Okay, you think like this, ye hoga. Then we help them to navigate emotions, engage intrinsic motivation, and also tell them to develop optimism. And definitely, after knowing yourself, after choosing yourself, you can give your direction. Because we have to talk to the adolescents in something which is, concrete or have some evidence. That is why I put the 6-second models apart from mental health first aid to help them that okay, or understand, anxiety issues especially, or then give them the calming strategies like count 10, which may work with the small children, but may not work with the adolescent. Then you can talk about 6-second model, give your break a 6 second. It is just a way to tell them that so that they can take care of their anxiety. And the last but not the least, just, 1 minute I will take. I had one 21-year-old, one of my relatives, I know. He is after post-COVID, he is now having anxiety to the extent of, heart problem, that I am having a heart problem, I'll die. And whenever there's a little bit of a pain, in the last 6 months, he has gone once in a month to the cardiologist or to the physician and also to the psychiatrist to handle this issue. Now, if I look back, his mother is also a personality having anxiety. So this child has been brought up in an environment where there was anxiety, especially, in the mother. And during COVID era, his father died because of COVID and multiple issues. So, and one of his friend died. So somehow there was a predisposing factor in the family. He was born up in the family where is a little bit of anxiety issues. Anxiety thing was there. And this COVID area incidences has brought him anxiety, which was not handled. And then, it has now turning into anxiety disorders. He's on the treatment because I help them during the panic attacks. I talk to them, listen to them, and try to calm down. He is getting a care from the psychiatrist as well as from, we are teaching mother also. But it is difficult. It's not that easy because जितना पुरानी होती जाती है ना बीमारी एंजाइटी डिप्रेशन वाली उतना ही treatment becomes very difficult. So here is the message, take home message is that catch them early if we can by any means and help them to not to develop into the patient with mental health issues later. So then only we can say that mental health first aid will be helpful. Thank you for patient listening.
Thank you so much, ma'am. Thanks for your phenomenal talk, explaining all the personality disorders or stressful condition by taking examples and explaining about why people break down, why they are more stressed, insisting on the use of counseling skills and reassuring adolescents to seek professional help whenever there is emotional crisis and using that as a remedial first aid for your mental disorders. And I really like the line, and I can take this as a take home message of your talk. Help the person in a concrete way in helping themselves. That is the crux of your talk, and I'm very happy and thankful to you, ma'am. Thank you so much. You had a great talk. Thank you so much. Atul sir, shall I invite second speaker for her talk? There is one question, ma'am, or shall we take now? In the chat box, there is one query.
If we have time, we can answer.
Okay,
Ask. Yeah,
after second talk, we can take.
no problem. Whatever.
Questions
Okay.
for ma'am's session.
Yeah. Okay, ma'am. So now I invite ma'am Shrestha to give her talk on dialectical behavioral therapy for emotional dysregulation in teens. I'm very happy, ma'am Shrestha, that you are doing PhD on this subject. Is a Shrestha job, I think, because incoming generation who is progressing in a lightning speed towards dysregulated emotions. So we are very eager to give you here to you, ma'am Shrestha. Over to you. Mic is yours.
Okay, ma'am, I would just like to mention if someone has to ask questions for Sunita ma'am's session,
Yeah, they can open their mic and ask.
you can take it, ma'am.
Yes.
I don't have any problem. I'll
Okay,
start after
that's
that,
great.
ma'am.
That's great.
Yes.
Has anyone wants to ask question, open their mic and ask question, they are allowed to do that.
I have posted one question in the chat box for Sunita madam. If
Sir,
you
can
can
I
see.
go through this and then talk about that later? So I haven't seen that. Shall I, just.
Ma'am, we'll just finish it off. There is a mental health issues are urban and rural as well. That is the only comment I think. Okay, now any other, I don't think so any queries are there in chat box now.
Last thing, I think.
So what? Sorry, what is that? Can you just tell me, Dr. Manjusha? I'm just trying to see, but
Yeah, I'm also trying because no MMC all registrations so many
No,
messages.
forget about. I'll ask it openly.
Okay, that can be.
Yeah, Sunita madam, if you
Hanji, sir.
permit me, can I ask you a question?
Sir, please,
It
Hanji,
is
sir.
regarding almost alternate families in India, that the children are living away from the homes.
Sorry, sir, I didn't get your point, sir.
Our children are living away from the homes. It's a very common thing.
Right.
And if the child says that there is no point in leaving, and the child is very far away,
Mm-hmm.
so how should you provide first aid mental health first help to this particular child who is in distress?
Sir, in that case, if he is living like what I advise in my one of the parents, she had like one his child or has faced in this. कि whenever you go in the institute, try to develop a support system over there. So at the time when he says, he should be whenever he is going to somewhere outside for start out of their place, because either he themselves should be strong enough to make connections in the place where he works, but we know we are living in a competitive world, and these generations are not very much going into have that social skills are decreasing day by day. But I ask these parents beforehand, if they take my advice, कि प्लीज ट्राई करिए वहां पर उनका सपोर्ट सिस्टम डेवलप, इट मे बी वन ऑफ योर फैमिली फ्रेंड, कुछ भी वहां पर है, पहले से ही एक सपोर्ट सिस्टम डेवलप कर लेंगे तो हेल्प रहेगी। आई थिंक वही उस टाइम पे, बिकॉज एट द टाइम ऑफ क्राइसिस तो सर जो उसके पास है वो कितना स्ट्रांग इनफ टू गाइड हिम, दैट विल बी द हेल्प। And institution also have policies, but again the person should be encouraged to approach them in case of need. And nowadays these adolescents are aware of these things as well, they're going into IT professionals and all that, but of course not everyone is there, तो parents को सर उसी तरह से guide कर सकते हैं। और sir, anything you would like to add on and tell us, I would appreciate that.
Okay. Anything else, madam? Do you suggest?
सर मेरे से ही कह रहे हैं सर?
हाँ जी मैडम।
अच्छा सर, मुझे तो यही अभी समझ में आ रहा है, या उस टाइम पे आई एम मतलब आप ही बताइए सर।
ओके श्रेष्ठा मैडम, हेलो आशी।
Yes, sir.
Please say something on this. I am your patient. I won't pay, of course, but tell me, if my child says that he is in distress, so how can I help him from Nasik? I am so busy with my conference, receiving people like Ritu Gupta madam, So,
Sir, in this case, it will be better if your child contacts with a professional there, wherever he's staying.
okay.
I think
सर
that would
one more point, sorry, yeah, please श्रेष्ठ मैम।
yeah,
सर
yeah.
हम
No,
अपने किसी कुलीग को वहां पर या somebody we can
yes.
ask them to go and help that
If
can
we do
also
have somebody who is also residing in the same place, if it is in India, it is easier because
Doesn't want to meet anyone, doesn't want to meet
network.
anyone.
Can I add something, Dr. Atul?
हाँ जी मैडम।
So this is my suggestion. Like as a parent, I would just like keep listening to my child. I will provide active listening. Just listen for like अगर बच्चा बोल रहा है कि life ठीक नहीं चल रही है, अच्छी नहीं चल रही है, सब खराब है. So I'll just keep listening for, okay, beta, why do you think so? Why do you think that it's not working? What is happening? So keep asking open-ended questions. Provide that space where the child can openly share, open up, vent out whatever he's dealing with. And like, so I'll give an analogy. If suppose somebody is drowning in the sea and you don't know swimming, but that person is asking for help, तो आप वहां शोर पर बैठकर भी you can just ask, okay, look around. I understand. First of all, empathizing, okay, what that like person is dealing with, getting his world पूरा समझ के, and then guiding, okay, what do you see around? How can you navigate through this? What support you can reach out for? What do you see? क्या पकड़ सकते हो? Maybe कुछ लकड़ी का तिनका, something which he can hold on to. So we can really support sitting, even, virtually, sitting at distance, we can really empower our children. And once they are like slightly empowered, slightly out of it, then they can definitely reach out for whatever help we can take support and do anything else. So that is what my say is. Thank you.
Does anyone wish to add? Poonam madam?
Sir, I was out of this session for almost
No, the question is
15 minutes.
Yeah, the question is,
Yes.
if your child is away from home maybe in some other country, and the child says that there is no point in living now, how can you help from, say, I am from Nasik, so how can you help from Nasik or Devas? That type of question.
So definitely the points which Ritu has highlighted, that we can definitely talk about, or we can just be on listening mode. At the same time, I will try to contact his friends so that they can reach out physically and be with him.
Yeah, that has already been told by Sunita madam
Emergency
and
services.
seconded by Shrestha madam also.
Yes, yes, yes.
Tell us something new if you can.
So I haven't heard that session, that discussion. So what else we can do? I think this is the best thing, or even we can activate the emergency response system of that country.
Yeah.
Okay.
Sir, can we, I mean, use the technology at that point of time? Uske kuch, I don't know, but I'm just asking you.
What type of technology?
Sir, अब IT मतलब उससे कुछ ना कुछ, you know, some information.
Gadgets for suicide वगैरह, something like that.
पता नहीं
No,
sir,
so
I'm just,
actually, if it is suicide, so there has to be somewhat something for the emergency services.
it has
Yes.
to be. Yeah.
It has to be. We have to include the emergency services. If there are thoughts of ending life,
Yeah.
then even if the person doesn't want, we still have to involve emergency services.
Okay. Okay.
And
ठीक
for
है.
that, even for activating response system from his friends, we have to know them previously also. So it is always good to entertain his friends, talk to them in between. And like what I personally do, I keep on talking, chatting to most of his friends. And usually on his birthdays and on his special days, I try to give some surprise through his friends. So they are really connected to us in that way.
Okay. That is quite satisfactory for me for the time being. Okay. So, Manjusha madam, please go ahead with the proceedings.
Yes, sir. Thank you. So can I hand over mic to Miss Shrestha Chattopadhyay for
Yes,
your talk?
it's visible, no, ma'am?
Yeah, it's visible and you are audible also.
Okay. I hope this is not affecting the chat box would be there displayed
No,
beside.
no, it's okay.
Okay,
It's okay.
okay.
Yeah, okay.
Okay, good morning. A heartfelt gratitude to Maha, IFB, Academy of Pediatrics, and a special thank you to Poonam ma'am for inviting me for this session. I'm actually very grateful. Today, my talk is on dialectical behavior therapy for emotional dysregulation in teenagers. So, in my defense, I would like to say that this is a very big topic. Dialectical behavior therapy itself is a very big module of therapy, which almost requires about 1 or 2 months to train. Even like for my students also, we require a certain amount of period because it is huge. Actually, it has 4 modules, about which I will be giving a brief introduction to all of you. And I would also like to mention that dialectical behavior therapy is mainly for people with personality disorders, especially for people with borderline personality disorder. And I hope all of you are aware that personality disorder diagnosis is usually given to an adult. We cannot give personality disorder diagnosis to teenagers. However, especially borderline personality disorder or any kind of personality disorder usually starts during this particular period of time, that is the teenage. And of course, if during the teenage we are able to trace behavioral patterns which might lead to personality disorders in the future, it is always better to help them cope right at the beginning rather than it becoming a very debilitating problem later on. Okay, so we cannot start without talking about Marsha Linehan. who is the mind behind DBT. She has developed DBT for especially people suffering from borderline personality disorder, because she herself had been struggling from borderline personality disorder for a very long period of time. And the existing therapies at that particular period of time were not um, enough to treat this particular condition. Now, personality disorder is something that we in our world of psychology, in a world of psychotherapy, consider that it's not something to be treated, because that is the personality of that particular person. And usually someone with personality disorder does not really come to the chamber asking for help. It's usually people around who are troubled with the person. Uh, if a person who might come to us in the OPD asking for help has a personality disorder, initially, we may find that the person is struggling with a primary disorder, could be depression, could be anxiety, could be panic attack, could be food disorder, could be substance abuse. So initially, they would come in the OPD present with clinical symptoms of substance abuse, depression, anxiety. And as we continue therapy with the person for a significant amount of time, I would say about 4 sessions, we realize that the person is also having a certain pattern of personality, which may be any particular kind of personality. However, right now, ICD-11 has released, and if we look at DSM-5, DSM-5-TR, you will find that there are 3 clusters of personality disorder. There is cluster A, cluster B, cluster C. Borderline personality disorder comes under cluster B. And there are 4 others: narcissistic, antisocial, histrionic. So it comes in cluster B, borderline. However, ICD, that is WHO has released a statement through ICD-11. It has not divided personality disorders into clusters. So currently the stance is that the person is having a personality disorder. It could be mild, moderate, or severe. This is the current stance and in ICD-11, and we will also start following that, rather not categorizing people into clusters. However, borderline personality disorder is a real thing, and initially psychodynamic therapy was generally used to treat it. However, cognitive behavior therapy was also being used, but a lot of other things needed to be managed, and hence Marshall Linehan and DBT. So just a quick run through about the what would be the symptoms of borderline personality. And this starts very early, like by the age of 13, 14 years of age. So that is why it's a personality. The person develops a personality, and we can help the person manage it. We cannot help it's not about treatment. We're not treating a person with personality disorder. We're just helping the person manage the problems that the person might encounter in their daily life due to the aspects of their personality, due to their personality organization. So people with borderline personality have strong fear of abandonment. They have unstable relationships. So very characteristic of such people, you will find that the very good friend of theirs will become their biggest enemies. They will not have one single person whom they would consider a very close friend. And even relationship with parents are also not very stable. They will they have spoiled relationships based. So we call this an unstable, and you will find this across different dimensions. That is at home, with parents, with friends, at the workplace, with colleagues, with every set of people, they will have unstable relationships, poor or distorted self-image, dangerous or impulsive behaviors, self-harming or thoughts of suicide, rapid mood changes, distrust of others, especially authority, anger issues, and dissociated feelings. So, like me being a student of psychology, clinical psychology, we often used to be asked by our professors that what is the difference between suicide and deliberate self-harm. So deliberate self-harm is something which is associated with borderline personality disorder, where the intent of self-harm is not dying, but to seek attention. So whenever we find any kind of self-harm behavior among teenagers, we generally try to understand that what was the intent of doing that particular act? Was it to die, or was it to, make others regret? They might have had some kind of, issues initially, and due to which they now might be, cutting themselves. So do they want that particular person to regret this particular, so intent, what is the intent of that particular self-harm behavior? And this is very important, that about 70% of people with borderline personality disorder, they experience maltreatment during childhood. Most of these people, they have a very disturbed home, conflicting family members, always, they have grown up seeing their parents fighting almost all the time, which actually affects their personality orientation. So now, dialectical, what does this particular word dialectical mean? Because it's important for us to understand. So dialectical, basically it has two aspects. One is about the nature of reality, which is a philosophical position, and the other is about the dialogue and the relationship that we establish with our client. So from the philosophical aspect, we have to see that DBT considers reality as dynamic and an interconnected system. So in DBT, we did not consider the reality to be absolute. We consider that the reality could be flexible. So there is a holistic approach. And, like as psychologists, we do consider the neuropsychological aspect, but we also consider that the behavior that the individual is showing, why is it within the context of their environment, their culture, and other systems. We believe that we can train people by helping them learn skills. Every person can help themselves, but they just need to learn those particular skills. However, before learning the skills, they need to accept themselves the way they are. I'll be coming to that in the next slide. Contextual and feminist perspective. Feminist is not basically, I'm not talking about, females. Feminist perspective is basically looking at someone from that particular perspective, from which they're not usually looked at. So technically, if I say in psychology, in the field of psychology, we find very less males studying the particular subject. So even that could be a feminist perspective. If I want to know the perspective of male students in psychology, male students who take up psychotherapy, what is their perspective? That is also a feminist perspective, because the usual kind of perspective that you would get would be a female dominated kind of perspective, because most of the professionals in psychology, at least, are females. So in dialectics, in DBT, we consider their perspective from the non-dominated point of view as well. So we are considering both, has to be holistic. We must consider that our therapy journey will not be very smooth with a person having a borderline personality organization. So as a therapist, I will tell you that people with borderline personality disorder, it could be teenagers whom we have not diagnosed as borderline personality disorder, or it could be adults. With both these groups of people, the kind of dynamics that we have to maintain has to be very calculative. It's almost like, walking on landmines, because every time they have a tendency to project us as that particular authority figure with whom they have a conflict. So maybe they have a conflict with their mother or their father. Now they are in therapy with us. After a few days of therapy, they start doing the same kind of behavior that they generally do towards their mother or father towards us. They will ask for the similar kind of favors. They will ask for similar kind of, privileges. And now, if we resent, they start doing the same kind of behavior towards the therapist. So therapy for this particular set of individual is also very tricky. However, when we talk about this balancing the need for self-acceptance with the need for change, is that we need to first make them aware that, okay, this is you. These are the problems that you have, but then this is you. You do not have to be ashamed about it, and it can be changed. So you can develop certain skills and you can change. Because again, for a lot of people who actually finally realize and come to the realization that they do have a borderline personality organization, it's very disappointing for them. It's very depressive for them. They lose hope. They feel that, what else could I do in life? So there we have to say, this is you. This is fine. You're a fine mess. That's fine. Let us now try to, change those particular things which is, causing you trouble. So this is basically what I was talking about. Now, let us talk about the model of emotions, the DBT model of emotions. So in DBT, emotions are considered to be brief, involuntary. So it's not in our control. Full system responses to internal and external stimuli with evolutionary adaptive value. So I have not brought the biosocial model by Linehan here. I have not shown it. It's a very big, complex model. But Linehan considers both perspectives. She considers the evolutionary aspect, that is certain things that we kind of, bring with us by virtue of our evolution, certain things that we bring by the virtue of our genetics, and then the external stimuli, which is, the interacting with each other. So emotion consisting of 6 interacting components: emotional vulnerability to cues, internal and external events as emotional cues, appraisal and interpretation of cues, response tendencies, non-verbal and verbal expressive responses, after effects. I'll run through this right now, because since emotional dysregulation is our main theme today, so what is emotional dysregulation in DBT? So it consists of 3 things. First is pervasiveness, second is emotional vulnerability, and third is systemic dysregulation. So what is pervasiveness? By and large, emotional dysregulation is the inability to regulate emotional cues, experiences, actions, verbal and non-verbal responses despite efforts. So pervasiveness, the first characteristic, that is, it affects a wide range of emotions and situations due to high emotionality and so basically, if I'm angry, I remain angry for a very long period of time. If I'm sad, I am pervasively sad for a very long period of time, could affect through a very large amount of situations as well. So on multiple occasions, I will become sad. And after I'm becoming sad, it is difficult for me to flip out of that sad mood. I'm pervasively sad for a very long period of time. If I'm angry, I'm holding on to that anger for a very long period of time. That is emotional dysregulation. The characteristics: excessive painful emotions, difficulty regulating intense arousal, cognitive distortions, impulsive behaviors, poor goal-oriented activity organization. So as in, even if I have other activities that I need to complete, because I'm unable to get out of that angry state, I'm not being able to do those other goal-directed activities as well. Tendency to freeze or dissociate under stress. Often people with borderline personality disorder have dissociative stances as well. Emotion over control leading to pervasive negative affect and poor affective communication. Emotional vulnerability. So the threshold is very low. A very little amount of, so I would say ki maybe, 5 of us are here. The same incident has happened. Maybe, an earthquake is happening. Among those 5, the first one who is, becoming very jumpy and startled. So the threshold of every person is very different. One person is taking some time to react. The other person is immediately very jumpy and, making some kind of any kind of cries for help and all of that. So the threshold for these people with emotional dysregulation is pretty low. Sensitivity and intense response to emotional stimuli. They are sensitive and the response is also intense. So the moment they're getting angry, the angry reaction is also going to be very explosive. Slow return to emotional baseline. This is one of the main characteristics. That is what I was talking about. They have very difficult, they need a lot of time to return back to their, calm state, return back to the baseline, what we call it. Systemic dysregulation. So this is basically caused by this emotional vulnerability and inadequate modulation strategies. So what is emotion regulation then in DBT? So whom do we call an emotionally regulated person? So the core abilities of someone with emotion regulation is the person is able to inhibit impulsive, inappropriate behavior related to strong emotions. So you're experiencing very strong anger, but you're not raising your hand and slapping the other person. Act in a goal-directed manner, independent of mood, irrespective of you being affected by certain things, you are able to continue with your daily activities. Self-soothe physiological arousal from strong emotions, refocus attention amidst strong emotions, conscious control and practice. There is initial focus on increasing conscious control over emotions, practicing skills until they become automatic. So basically, someone who is having emotional regulation will be practicing not losing their control over a particular period of time, and so much so that it becomes an automatic response. Will I be taking questions now?
No, ma'am, you need to finish your talk first.
All right, all right, all right. So, okay, so these are the 4 modules of DBT. Okay, so DBT is basically done across 4 modules. All these modules are independent of each other. They're interrelated, but they're independent of each other. So whenever we approach a client, we generally pick up skills from each of these modules depending upon the needs. So these are the 4 basic modules. The first module is of mindfulness, that is being aware of the present moment without judgment. However, so DBT skills book is a very big, thick book, and it's a very interactive book. The book has everything written in summarized versions. What are the exact kind of instructions we require to give? What are the tips that we require to give? Everything is there in the manual. I can share it later on if any of you are interested. So this is, as you would see, I'm just raising this above. So these 2 modules, that is mindfulness and distress tolerance, is for acceptance. If you remember, like accepting yourself for who you are. And for changing, it is emotional regulation and interpersonal effectiveness. So for acceptance, the modules are mindfulness and distress tolerance. For change, the modules are emotional regulation and interpersonal effectiveness. Why distress tolerance is there in acceptance? Distress tolerance is basically for managing crisis situations. Since people with borderline organizations tend to have self-harm tendencies, so this requires the need for crisis management. And for crisis management, then there are a set of different skills which are required, because that is of immediate attention. What happens is people with a borderline personality organization, they may indulge in self-harm behavior without the intention of dying. However, sometimes accidentally they may die, they may lose their life. So that is why distress tolerance is important. I will be focusing on this module, emotion regulation. Emotion regulation module has again many different types of skills. I will be focusing on 2 skills which I use widely with especially teens. So I'll be discussing 2 specific skills. However, there is a list of skills that we can use for emotion regulation. So for teens, what could be the challenges? So any teen who is also, something that I have come across while seeing teens currently, the Gen Z generation of Gen Z, Gen X, Gen Alpha. So basically what I have found is the life that they have is very fast. Their life has become very fast. They have grown up faster than we did. They also sometimes joke with me that, ma'am, I look older than you. We tend to have dark circles. We tend to have all kinds of, things on our faces. Before, I think, our elders had it. And it is true. They actually look older. Their skins have aged. Uh, so this is true. What I have also found in a typical room, if I sit with the Gen Z people, I mean, my students also, they're all Gen Z. So they communicate with each other through texting, through Snapchats, through WhatsApp. They have stopped talking to each other. And unlike when we were in our classes, we used to raise hands and we used to ask questions to our teachers, they are more comfortable texting to us. They're more comfortable asking questions through texts. I poke them a lot, ki ask questions, discuss, or I have to introduce discussion sessions, keep separate sessions for discussion because they don't speak. I don't know. Another thing has been COVID. With COVID, the online interaction has increased even more. But it is very weird. I mean, maybe they're just sitting in benches beside each other, but still they're sending reels to each other. And then they're looking at each other and laughing at it. They don't show the reel to them directly through the phone. Ki look at this reel and all that. So there is this gap in communication. They have become very impulsive. They have actually extreme challenges in emotional regulation. They have explosive emotions. They get angry. They get affected very easily. So it could lead to various dysfunctional behaviors. If they have difficulty in regulating painful emotions, it can lead to various dysfunctional behaviors, which could be suicidal behaviors, substance use. Again, teens these days are very much prone to substance use, overeating. Eating disorder, something which was mainly found in America, now is very prevalent among the Gen Z generation. I mean, it's not prevalent in our generation, but it's very prevalent in the new generation. I have found people with bulimia nervosa who, they're actually vomiting out the food, feeling that they've eaten a lot. Emotion suppression, over control, interpersonal conflicts. Teens often use these dysfunctional behaviors to cope with intolerable emotional pain. Teens with high emotional sensitivity or frequent distress need help in learning to regulate their emotions. And it's also hard to teach due to previous negative experiences with advice like change your attitude. So, we being the adults, our way of suggesting them should not be like we are giving them advice. We are asking them to change their attitude. So it is very important for us to first, tell them that we accept you the way you are. It's fine. But you are also, having certain difficulties. I mean, you're not being able to maintain a stable friendship. You're not able to maintain stable relationships at your workplace. So could we just, change a few ways in which you interact or the ways in which you manage your emotions? I think that would help you. You're perfect the way you are. I mean, that validation has to go out for this particular generation a lot nowadays. And I mean, if you look at the kind of reels and everything that they share, also is all about self-care and self-validation and love yourself and all of that. So some teens come from environments where emotional control is expected and deviations are disapproved. Resistance to emotional control can occur if teens feel that it invalidates their feelings. So we cannot control them without invalidating their feelings. So these are the two skills that I'll be talking about. The first skill is understanding and naming emotions. So again, this is very important because teens, again, hardly speak these days. But one thing that I would always recommend is that before you do the skill on someone else, try it on yourself. These are very simple skills. We can try all these skills on ourselves. We ourselves have difficulty. We will find that we are having difficulty in understanding and naming the emotions that we are experiencing. So the steps in understanding and naming emotions, the first would be identify your own emotions. The simple act of naming your emotions. So some people always know what emotion they're feeling, others have no idea. Understand what emotions do for you. So first you name the emotion, then you understand what that particular emotion is doing for you. Suppose whatever emotion you're feeling right now, if it is fear, try to understand how is fear helping you? What is it doing for you? Once our emotions are understood, then the frequency of it can be decreased. So this is part B actually. Part A is understand and name them. Part B is now decrease the frequency of unwanted emotions. Generally, it is fear and anxiety in this case. Anger and fear in this particular case. So understand that if you are getting frequently angry, then you need to reduce the frequency of getting angry. So how do you do it? Stop unwanted emotions from starting. So first we try to control the stimulus. You stop that unwanted emotion from starting itself. So changing your environmental situations, removing yourself from a certain person who might be the trigger for anger. If that is not possible, change the painful emotions once they start. So you cannot, maybe the trigger is your mother, or I'll give you, I think, let me make it distant. Trigger is mother-in-law. Okay, so one particular person, the trigger is mother-in-law. Mother-in-law is always making certain kind of comments, and this lady, she is getting angry. She feels that there is, stark difference in the way in which she treats her daughter and the way she treats her. This is a very recent discussion that I had with one. So she told me that, how will I change my anger? So I told, change your anger into disappointment. So actually in DBT, we have a whole set of emotions of what we can change into what. So instead of feeling angry, feel disappointed. So that will change the explosiveness of the outburst that you're having. If you're angry, so then it means that you have certain expectations. But if you're disappointed, the expectation part is less, and the explosiveness of your anger will also be less. After that, if we also sometimes, I also tell one thing, do not be surprised if this thing happens with you. Rather be surprised if she does something special for you. I mean, if she's doing this on a regular basis, then why is it surprising you? You know that she is going to make some comment on your spending, on how, deliveries come from Nykaa every day. If she's, I mean, don't be surprised. In case if she appreciates you for certain things, rather then you should be surprised. So we are changing the painful emotions once they start. Okay, emotions themselves are neither good nor bad. So emotions are emotions. Just telling that this is bad and I need to get rid of it is not going to help us. Also, there is a myth that we should suppress our emotions. I'm not telling to suppress emotions. Suppression of emotions is going to make it even worse. 5, emotional regulation is ineffective. And also we have to remember that you don't have to regulate all your emotions. We are regulating only those particular emotions which are ineffective, which is not helping me in any way. I mean, getting angry with my mother-in-law is not going to help me in any way. It is actually creating a discord between me and my husband later on. So let us just focus on those emotions which are ineffective, which is not helping me in any way. Next, this is decreasing vulnerability to emotion mind. I will be talking about the emotion mind in the next slide. And decrease emotional suffering. So when emotion regulation will enable you to decrease your emotional suffering, you will learn to do these two things. That is, reduce suffering when painful emotions overcome you, manage extreme emotions so that you don't make things worse. This is the part, emotion mind. Actually, this is a concept from the module of mindfulness. If you remember the first module of DBT, which is mindfulness, there we generally tell our clients about this particular concept, that this is Marsha Linehan's analogy, metaphor, basically. She has helped us, explain it to patients in this way. We have 3 minds: the emotional mind, the wise mind, and the rational mind. The rational mind is basically one which is based on logic, which gives us facts, which is based on statistics. The emotional mind is reacting out of anger, reacting out of fear, reacting out of feelings. Wise mind is basically a balance between both. How do we know that when we are reacting in a situation, we are reacting from our wise mind? So Linehan says that if you don't regret your actions, if you don't regret what you did long after you have done it, then probably what you did was from your wise mind. But if you regret your actions, if you feel that I could have done this better, or I shouldn't have told this, or I shouldn't have done this, then probably you reacted from your emotional mind. So this particular logic which we are talking about, the decreased vulnerability to emotional mind, is this. It's try not to react from the emotion mind, try doing it from the wise mind. And this usually will happen if we pause, like certain thing happens right in front of us, take a pause, a breath, and then react. That pause will immediately shift you to the wise mind. But the immediate reaction that we do is usually something that we do from the emotion mind, and it, makes us miserable or guilty later on, usually. This is the list of emotions actually. So if you could see, the primary emotions are anger, sadness, fear, love, joy, surprise. And then there are some secondary emotions, like the primary emotion of anger is also consisting of secondary emotions like irritation, exasperation, rage, distrust. For sadness, you can find suffering, sadness, disappointment, shame. So you will find a lot of lists. DBT has its own list of primary and secondary emotions. A list of emotions is important because when our clients find it difficult to name their emotions, we give them the list that, circle out whichever you feel that you're feeling. This is a mnemonic that we generally use for the whole emotion module. This thing, we have a mnemonic. So Marshall Linehan has introduced mnemonics for every module. So the mnemonic for emotion regulation is ABC, please. A is accumulate positive experiences. B is build mastery. C is contribute to your world. For please is basically our own physical fitness, basically. So treat physical illness. PL is for physical illness. P and L is basically that. E is balance eating. A is avoid mood altering substances. S is for balance sleep, and E is for get exercise. And there are several tips for each of these mnemonics also. And as you could see, actually, these are the things which generally get disrupted for someone with borderline personality organization. They have difficulty in maintaining their eating. They use mood altering substances. They have difficulties in sleep, and they're not very physically active as well. And this is the last skill that I will be discussing with you. One thing that I also use with most of my clients is how do we change our emotional responses? So this is known as the check the facts. So these are the 2-3 kinds of techniques which are used. Again, as I would say, okay, all this has several tips below it. Okay, like check facts, opposite action, all of it has several tips below it. So for changing emotional responses, we have check the facts. So checking the facts is basically, suppose we are on a bus. We see that our friend is also sitting in the bus. We are waving at our friend, but our friend doesn't wave back at us. So what is the first thought that could come to you? So if you think that your friend doesn't like you, probably, some personal thing has happened, and you might feel that, oh, my friend has got to know that I have, failed in this particular exam. And so now this friend decides not to talk with me. All right, fine, I'm also not. So without even knowing why exactly this particular friend did not wave back at me, I am making my own assumptions. So checking facts is very important before I, make some assumptions about a situation. Next is opposite action. Opposite action is what I was talking about, that one thing. It should not surprise you if your mother-in-law is behaving with you in this particular way. Rather, if she praises you over her daughter is something that should surprise you. So opposite action is when emotions do not fit the facts. Knowing the facts does not change your emotion, then acting opposite to your emotions all the way repeatedly will change your emotional reaction. So once you check the fact, what if the fact does not fit your emotion? The fact is something else, and you are being angry over your mother-in-law for something else. So it's not fitting, but still you cannot get loose of that emotion. Then change your emotion. And what if the facts fit that emotion? What if it is a real thing and whatever fact you're thinking is true? Then we should go towards problem solving. Then changing the situation is more important in this particular case. So we should go to more for a problem solving approach in that case. And this is the most interesting part in emotion regulation, the last one, the yes, but barrier to changing emotions. So doing what is needed to change emotional responses can be very difficult. It requires effort, willingness, and an ability to determine what is in one's own best interest. Yes, but is a typical response to efforts to help a person change emotions, particularly when emotional intensity is high and changing emotions is experienced as admitting that the person's own feelings are invalid. So it's basically when one of my teens only, they say that, my best friend is now hanging out with my boyfriend, and I probably feel that, both of them are dating each other. And I'm trying to talk about, okay, what are the facts that, they are actually dating each other. I mean, there are nothing of that sort. I mean, my boyfriend still loves me, but there is, so this is the yes, but scenario basically. So the problem is that yes, but does not lead to feeling better or solving emotional problems. So when yes, but rears its head, it can be useful to remind participants that there are only four possible responses to any problem. Solve the problem by changing the situation or by leaving the situation. Change your emotional reaction to the situation so that the painful emotions are reduced, even though the problem remains. Radically accept the situation. That is, acknowledge that the situation can't be helped and you can't change how you feel either, but that completely and willingly accepting this state of affairs can give you a sense of freedom or reduce your suffering. Or fourth option is stay miserable. So Marshall Inahan is also very much, she's very straight. So the way of counseling she used to do is very straight cut. See, nobody promised you that life is gonna be a bed of roses. So what if this is happening with you? So she also has that way of approach. I will be sharing the skills manual worksheet if you are interested, because it's huge. DBT is huge. And of course, I will be glad if, pediatricians are actually the first point of responders when it comes to teens, adolescents, and you will find these kind of emotional dysregulation among teens in today's world, and helping them cope with certain tips would be definitely helpful. And in that way, I have always felt that with teens, I kind of, become their friends. They are very comfortable sharing certain things which they do not even share with their parents, and I always feel it's because their parents are very judgmental. I mean, if somebody likes K-pop, don't be judgmental about it. Just go and ask you, okay, who's your favorite band, and who's your favorite K-pop musician? Oh, you like him, huh? I like him too. I mean, I think that kind of validates them, and then they might come up with their issues and their problems that they're dealing with. The moment I misjudge, I mean, I judgmentally kind of say ki, oh, you like K-pop, I mean, I don't understand K-pop, ya pata nahi aajkal kya hi in logo ko ho gaya, and all that. The moment they will just they will decide, oh, this person is just like my parents, they're not going to do anything good for me, and there's no use discussing with this particular person. So I think it's important to come down to their levels, and we can be the first point of contact and the first point of help if we want to. Thank you so much.
Okay.
Thank you. Slide is here.
Thank you so much, Ms. Reshta. I think your talk itself is a behavioral therapy for us for more 20-25 minutes, because some of the other, each one is finding the same things what you narrated within ourselves also, few stressful conditions, and your examples were connecting with many situations, and I really like your connect to the audience and the flawless talk, and I'm very happy with the talk. Congratulations, and
Thank
thank
you.
you for making us realize the fundamental concept of DBT.
Thank
And
you.
the therapy lies in the knowing, holding back our strong emotions, and increase distress tolerance abilities, and interact the people around you, and checking the facts, and then only believing the situation. Move away from the stressful situation, and regulating only ineffective emotions. Don't try to control yourself and become like ideal person. You are
Yeah.
human beings, you are there. So only the situation which takes you to the stressful situation, that we need to control. And we really learn the four modules of your DBT, and challenges in the teens, what you narrated. And teens are really beyond our control. But I don't know, whenever situations comes, we people know some personalities around you needs to be changed and they needs to take therapy and they doesn't reach the therapist. That is the main hurdle I always feel. Becoming we more wiser and that person doesn't know. So we have to
Yes.
change our attitude while reacting to him. And really, I like again the sentence accept yourself the way you are and lead the life successfully and more confidently. And many more take home messages I really liked: wise mind and emotional mind, and like find a golden like middle of the situations and use pause, breathe, and then only react. So many things, but we need always repetitions of this thought. This
Yes.
therapy, we can't just listen and finish it off. I may be the same person after some time. So I'm really happy. So we like to you call all you people again and again on this board. So those attendees, like more than 150 people were there. So free of cost, we got your therapy, ma'am. So thank you so much. Thank you.
It's my pleasure, ma'am. It's my pleasure. Thank you so much, ma'am.
Atul sir, you want to say something, or because it's already 12:15, it's just closing time.
No,
And
it
I
was
think Ritu Gupta ma'am wants to
yeah,
ask something.
both,
Ma'am,
both,
Ritu Gupta.
both the sessions were fabulous. And we are rather delayed by almost 1.5 years to invite these two specialists here, Sunita madam and Shrestha madam. Shrestha, as the name is, she is actually Shresht in her field, and she has done a wonderful deliberation. And of course, Sunita Mandaleta Manchanda madam. Yeah, sorry, Sunita Manchanda madam. Her talk was also excellent. I have just one question for Shrestha madam. কিছু করবে না ম্যাডাম জাস্ট ভালো
Thank you, sir.
তো
Sreshta, yeah, by mistake, I was calling you again and again, Dr. Sreshta, but I'm happy that you are doing PhD. So
Yes.
I will ask you again when I have to add Dr. Sreshta behind you.
so my question to you is how do you differentiate say psychosis or thought disorder from personality disorder? Because the way you have described
Hmm.
personality disorder seems more common than anxiety,
Hmm.
especially in teenagers. So
We
what would you
usually,
comment?
uh, generally, sir, there won't be any breakdown in the usual activities. So they will be going to school. They know that, they're not faring well in their examinations. So there won't be any kind of delusional thinking. So if it is a thought disorder, they will have some very high aspirations. Like they're failing in examinations, but they will say that, I want to prepare for UPSC. Things that we find that, it's not going across. But someone with a personality disorder will not lose reality contact. They will say that I'm a failure. मुझसे और कुछ नहीं होगा. I won't be able to do anything better. And in that case, it's more like we trying to help them understand ki, look, you have this potential in you and you will be able to do this. Let us try. I mean, recently, I mean, the current borderline patient that I'm dealing with is a nursing student. And he had come with telling me that, ma'am, I have not studied anything in my examinations and I'm going to fail. And there it was again problem solving strategies that we used. We told him just get all the previous year's papers, and we made him. So he will procrastinate. He will not do all these things by himself. In the therapy sessions, we used to make him sit with the question papers and tell him ki pick out those questions, which are the common questions and all that. Next challenge he told me is ki he's having difficulty shifting from one hostel to another. So then when I told him, look, you were very much doubtful about yourself passing in the examinations, but you did it. Then he was like, yes, ma'am, I passed all the examinations. I couldn't believe. So these people are usually very self-critical of themselves. But someone with thought disorder will not be like that. Thought disorder people will generally have very grandiose ideas about themselves. Also,
What about
use psychology. We
what
use
about
Rorschach.
what about moderate to severe depression? How is it?
Very common, sir. Among people with borderline personality organization, they will have moderate to severe depression. And usually, if they are coming on their own to the clinic, it's because they're having symptoms of depression, because, sir, their perception of the world is only very biased. So things which may not affect us very easily will affect someone with a borderline personality very easily. So they are prone to get depressed more often. So they will have panic attacks, they will have depression, they are prone to abhi now DSM-4 axis is no longer used, but in DSM-4 TR there was axis 1 and axis 2. In axis 2 personality disorders used to come. So we consider that axis 1 disorders are very common in personality disorders because their view of world is very biased.
Any drugs you can suggest which are useful for treating personality disorder?
This usually goes with the psychiatrist, sir. But psychiatrists generally treat the axis 1 disorder. So if someone is having symptoms of depression, there are no drugs for personality disorder. So if a psychiatrist feels that this particular patient does not have any kind of axis 1 disorder currently, only personality disorder, they send them directly to the psychotherapist. If they see that
How would Sunita madam give first aid to your case of say personality disorder? Sunita
Ma'am,
madam.
unmute yourself. Sunita ma'am, unmute. Unmute, ma'am.
Hello. Yes, sir. Sir, I
How?
think, yeah, as I had, I would rather prefer with the kind of, experience I have to the parents and for the child adolescent, I would definitely involve the clinical psychologist or the psychiatrist as well. So this is the way I would like to go with it.
पूनम मैडम आपकी मधुर आवाज
जी सर बिल्कुल बोलिए
सुनाइए.
तो सर श्रेष्ठा, she is the clinical psychologist to whom usually I consult or I refer my patients to, and I was really very much satisfied with the way she deals with the patients. So that is why I suggested her name.
Great. रितु गुप्ता मैडम आप अपनी आवाज सुनाइए अनम्यूट करके.
Thank you, sir. So, sir, again, like as Dr. Poonam and Dr. Sunita said, to first aid, if I am the pediatrician, I will give the first aid. I will again say active listening and just providing non-judgmental listening will be very important, critical. And once I have emptied the child, I can always take support of psychologists and psychotherapists and other specialists.
Great. So over to you, Manjusha madam, for your concluding remarks.
Yes, thank you, sir. Now it's a time for vote of thanks, and my first and foremost gratitude towards today's adolescent specialist speakers. They were wonderful today. Thanks to Dr. Sunita Manchanda ma'am and Ms. Shrestha Chattopadhyay for your excellent talks and discussions. Thanks our President, Mahayapi President Dr. Ram Gopal Chejera sir and Honorary Secretary General Dr. Amol Pawar sir for making this platform to available for today's wonderful discussion. And thanks Dr. Kanikar sir for being the central coordinator for the project PATH, which is running very successfully since 2023 under the guidance of Dr. Dr. Ramakant Patil sir and Dr. Amol Pawar sir in their presidential and secretaryship in 2023. And thanks all the dignitaries who all have joined and very enthusiastically participated in this discussion. And thanks dear Pallavi ma'am for your digital support, which is always precious for us. And here we end the session and have a nice day to everyone and take very good care of yourself, not only physical, but nurture your mental health also. And thank you so much and hope to see you all again on this beautiful platform. Thank you. Thank you so much.
Thank you. Thank you very much.
Thank you, Manjusha ma'am, for moderating the session very well with your catchy inputs and catchy lines. Thank you.
Thank you.
Thank you, Shrestha ma'am. Thank you, Sunita ma'am.